Well, thank you everyone for joining us. My name is Dennis Cleary. I'm a senior researcher at Cincinnati Children's Hospital, and I'm really excited to be joined today by Dr. Sue Bazyk. Sue, could you just tell us a little bit about your background and how you became interested in addressing the mental health needs of children and adolescents?
Great to be here, Dennis, and happy to be chatting with you. Well, I've been an occupational therapist for over 40 years. All of my clinical experience has been in home, school, and community settings. So I've always been a very community-based OT. I'm a professor emerita, which means I'm retired from teaching at Cleveland State University, where I taught for 34 years. And in terms of mental health, I guess I always took very seriously OT's roots, that we believe in the use of occupation to promote health, both physical and mental. And so all throughout my clinical career, I always tuned into the mental health needs of the children I served, children with food refusal issues. I hated them referred to as behavior kids or behavior feeding. They were children who really were struggling in terms of their mental well-being related to their relationship with their mouth, with the feeder, with food. So I've always been very interested in mental health as a part of who we are as OTs. I really don't like it being separated. And then in 2000, I was invited to an AOTA think tank meeting. Barbara Hanft and Leslie Jackson, leaders at AOTA, brought together 20 OTs for this 2-day think tank meeting, thinking about what is our role related to children's mental health. And the impetus was the Surgeon General's report in 1999 on mental health. And he called for reducing stigma and more attention to mental health promotion and prevention. And really that what we found and realized in 2 days of thinking about our publications, what we were doing, that we really didn't have anything in our publications on promoting positive mental health and prevention. It was all intervention for kids with challenges. So that's really what lit my fire.
Gotcha. And then from that, part of your fire was creating Every Moment Counts. Could you just talk a little bit about that? And that's been most of your life work since then, right? In terms of occupational therapy. Anyway.
Right. We just have our 10-year anniversary when this initiative was launched. But what happened was I began to publish more and asked to publish more related to children's mental health. And I started reading probably around 2005 after my dissertation, which really focused a lot on social emotional learning and occupation-based services for low-income urban youth. I started reading about this public health approach to mental health. Georgetown had one of its first monographs on that around 2008. And then I had an opportunity to write a book for AOTA. And I spent a long time reading about this tiered public health framework and what mental health promotion is. There's actually whole books on mental health promotion and mental health literacy and positive psychology. And all of that I was mulling around, and it really shaped the 2011 book that I edited on mental health promotion, prevention, and intervention, a guiding framework for occupational therapy in working with children and youth. So I had several other authors as a part of that book, and we all agreed from the start that the book would not be about just intervention for those with challenges, but for every group of children we had a chapter on, like ADHD, learning disabilities, autism. We were going to focus on how to help them be mentally healthy. And so after the book came out, I remember just thinking, well, who really cares if nobody reads it, if they don't really digest this material, and if it's not applied, it really doesn't matter, that this book was published. And there's so many publications that really aren't applied in practice. So I started learning about knowledge translation and implementation, and I developed this building capacity process.
Hmm.
And so I really didn't get funding, but I said, well, what if I brought together 14 OTs to be a part of a community of practice, to read the whole book, and every two chapters discuss the chapters and how they could apply it to practice. And so we did that, and they were so excited about thinking about mental health as not diminishing mental illness only, but promoting positive mental health. And so then, midstream in that 6-month process, I heard about funding from the Ohio Department of Ed, and they wanted something related to mental health. So we, the 14 OTs and myself, the guiding question, this one meeting was, now that you know about this framework and occupation-based practice, what should practice in schools look like?
Hmm.
And it was during those 3 hours that we really talked about a lot of things, but we said it can't be 1 hour a day. It has to be embedded throughout the
Hmm.
day. And we envisioned every moment counts. We were funded for $720,000 for 3 years. And it was that group of OT change leaders and myself that really developed everything over 3 years, implemented it, and evaluated it. And then it's just carried on since then.
Yeah.
It's been really an amazing journey.
Hmm. And it seems like, and I don't know if it's your interest in public health, but when you go to your website, which is everymomentcounts.org, is you just have incredibly user-friendly resources that talk to different communities, that talk to the occupational therapist, but you also, give us language that we can use to talk to administrators and, very much about capacity building and what can we do to help transform practice. And where did those roots kind of come from in terms of what you were seeing? And I think I was fortunate enough to be in Ohio for a number of years, and it just seemed and I met a lot of the OTs because you started with 14, but how many OTs did you end up training in the state of Ohio by the time? I don't know, I'm sure it's still going on. Um,
Well, we replicated that building capacity process throughout Ohio as a part of the grant. We reached over 200 OTs, and that was published in AJOT, where we did see that learning over time within a community of practice, sharing success stories and challenges, that the therapists, we saw statistically significant improvements in not only their knowledge of this framework, but their beliefs that they should be a part of mental health initiatives in school, and then action. They did more. And our goal was to take this underground OT practice that OTs say we're holistic, but they can't describe what we're doing, to take it above ground. And so actually that initiative is now within an online course, and I've shared the information sheet for our listeners. And we've implemented this across the country, and capstone students are implementing it, and OTs in different states. And we did make it interdisciplinary. So the website, strategically, we knew that one or two OTs or one or two counselors in a school can't do this work. We really need all adults serving youth to tune into mental health and to be able to be a mental health promoter. Not everybody's a mental health provider, but everybody needs to be a mental health promoter within this tiered framework. And teachers love this information. Other school personnel, it really needs to be everyone.
Well, I think what I also really appreciated is it seemed that, because I was lucky enough to know a number of different OTs that you worked with, that they felt stronger about what they were doing and more confident about what they were doing.
Mm-hmm.
And I think even approaching administrators and even the Department of Education to really look at,
Mm-hmm.
size of caseloads and what was realistic, and really not just
Mm-hmm.
realistic, but what was best for the children and adolescents that they were serving. And I don't know if that
Mm-hmm.
came fully out of Every Moment Counts, but I know Ohio has some caps in
Mhm.
terms of the number of kids that can be on a caseload, and I'm in a state now where there isn't a cap. And
Mhm.
I was talking to an OT not too long ago that was trying to see 200 kids, and
Yeah. Mm.
you can't. And so I don't know
Right.
if that was coming from every moment counts or not, but
Well, I think we've addressed that, but I think there are a lot of issues related to caseload, workload, and the bottom line is IDEA, the law that brought us, full force into schools, states that our services should be LRE, in the least restrictive environment to the maximum extent possible. So that means the gen ed environment. And so what we try to get therapists to do is not an outdated clinic-based model, no matter how many kids are on their caseload. But when we integrate services in the natural context and we think about these tiers, universal being all kids or at a classroom level, tier two would be small group, and then tier one, which would be maybe more of your caseload model. When we integrate services in the natural context, we have access to all students and we maximize the impact of our services. So all children can benefit from what we're providing. And we did one study looking at integrated services years ago, and the principal said, I want to get the biggest bang out of my buck. So I want you integrated in the natural context. There are still too many supervisors of OTs who don't have up-to-date information or are misinformed. And then there are too many OTs who are stuck in a pull-out clinic-based model, which is not best practice. And so I think we have to work smarter, not harder. And you've heard of that saying before.
so there's a really nice illustration of the different tiers of looking at a public health model. And so how did you sort of get interested in it? You just felt that it was the way for you to kind of address the highest number of kids possible, and
Well, it goes back to that public health framework, a tiered public health approach to mental health. And tiered services have been a part of education for 20 years at least now or more. And RTI is a tiered model. PBIS is a tiered model. And so what we're doing with Every Moment Counts, it's the same type of tiered model. But one thing I make a huge distinction. Sometimes you'll see the pyramid with tier one being 80% of kids who don't have challenges. Well, really, tier one is all children and youth. That we need to focus on promoting what we want, positive mental health in children with and without disabilities and or mental health challenges. So that's why our pyramid, you'll see, looks different. And there's a lot of information, and we're really moving more toward this mental health promotion and prevention. But I do find that a lot of resources gloss over promotion and go right to prevention of problems. So tier one, mental health promotion, is all about evidence-based strategies that help children be mentally healthy. So it does include a lot from positive psychology. And so what we do as OTs in applying that, we really believe that what we do impacts how we feel and function. So we're not doing talk therapy, we're really helping children participate in occupations and interactions throughout the day that help them be mentally healthy. So that's tier one. Tier two is a little more specific, and it's tuning into all those at risk. That is students with disabilities that are at higher comorbid risk of mental health challenges, kids in poverty, those who've been bullied, even with obesity. We see increased mental health challenges. And so here we're a little more specific. And I think for OTs, because we all come into practice with a knowledge of running groups, what I love to see is OTs who are running small groups during lunch and recess with those tier two kids at risk with maybe peer buddies. So that's where we can serve more than one on our caseload during these non-academic times. And then tier 3, we really focus, we're usually not the go-to person for those with identified mental illness, but we need to help school personnel create environments that help children with mental illness, mental disorders, be able to succeed using accommodations and creating reduced stress, sensory-friendly environments.
And then how would you say that that is differs from a multi-tiered system of support?
Well, MTSS is a buzzword
Yeah.
now, and I've seen it with 4 levels, and I don't like to pick apart the different levels, but I think it's very similar to this tiered public health framework. And the whole gist is, really tuning in to all students, doing work to promote health and then to prevent health challenges. So I see them very much similar.
Yeah, and I think I know when I've taught public health models to students that I think those of us that have a little more experience, it's maybe, I don't know if it's easier for us to see the big picture. But a lot of times, when students kind of come in and sort of their expectation of what they're going to be doing in the school, a lot of times they really do see this one-on-one intervention. And so sometimes it takes a little bit of nudging. And I think
Oh,
that
yeah.
just the support that you provide on the website and the other trainings that you do
Hmm.
really help
Hmm.
to help OTs understand, what that can look like.
Right, right.
But could you talk about how looking at this kind of tiered approach can influence OT, our process of evaluation and intervention, and how we're practicing?
Right. Well, I do think working at the various tiers, and actually even with the tiers, they're not really dissected very clearly. So if an OT is providing services or co-teaching in the classroom, she or he is going to have her eye out or his eye out on children who are struggling. So even though you're doing a tier 3 or tier 1 type of service, you're layering in the supports for the children who may be struggling more. So they blend together, but that's a skilled therapist really has those skills. But I do think we need to shift. I would say in the 90s and before that, it was very one-on-one intervention, and then consultation became really big. And I think consultation has its place, but teachers are really stressed and overwhelmed. And so consultation, if we're just asking them to do more, I think that's problematic. And then they may struggle with having some therapists tell them to do this, do this, do this in the classroom. So I think when we add to our approaches like co-teaching, which Jane K. Smith, that we all know and cherish, she was one of the first that got me hooked on and thinking about co-teaching with her Right Start program. So that's going into the classroom and doing with the teacher or doing a unit of something related to what she or he is teaching. Coaching strategies are gaining a lot more attention. So that's working with, and in our cafeteria and recess programs, we're really coaching. We're developing relationships with the supervisors, modeling the kinds of things that we would like them to do. And modeling is very powerful. So I think, too, in applying this tiered approach, we do take our students at Cleveland State University into Cleveland schools, and they implement the cafeteria and recess programs. And by doing that, they learn how to implement a tier 1 service. And evaluation is different. Evaluation will be more like doing an environmental scan, which we have on our website. It's analyzing the context, the sensory, the physical, the social emotional factors. And then the program is catered to the specific needs of that cafeteria context, whether it's third graders or fifth graders or whatever. And so I do think it's a different skill set than one-on-one intervention. And our students need experiences, and therapists need, they need to develop, they have the skills, they just need to develop them And I see even practicing therapists kind of scratching their head and thinking, how could I do that? But then we have, I call them maverick OTs, who just jump in and do it, and they know it's right, and they have the confidence to do that.
Yeah, absolutely. Yeah, I know. I had one of my former students way back when had a son with Down syndrome that was in speech therapy in a public school, and went to an IEP meeting, and the speech therapist, she was asking her about, because we were teaching, let's that therapy is not this 30 minutes a week in a room. It really is, how are we incorporating that into this young person's every day. And the speech therapist said, I'm responsible for 30 minutes in this room. And that was kind of like, so she came and we sort of problem solved how we could look at that. And but I think it's helping, what is really kind of going to be best for this child. I've been working a lot with some Canadian OTs recently that and Canadians are really, their OTs are in the schools, but not to the level that we are, and are starting to get a little bit more involved in the schools, and some of them shake their heads on occasion about some what school-based practice is, and one of them in particular is, and she does transition like I do, and her point is, why are we working on anything that is not going to help this kid when they're out of school? That we have a limited amount of time that we have to support these young people, and how do we kind of get the best bang for their buck, or give them the skills that they really need, so they can be successful for a lifetime. And obviously those positive mental health skills are a huge part of that. So fun little story. This young man I saw recently is in the marching band with the high school that he's going to, and he was um, just saw him in a 4th of July parade. So it's kind of fun that apparently these communication skills he was developing have moved from beyond that 30 minutes a day, or 30 minutes a week that he's there. So could you talk a little bit more about Every Moment Counts, and the types of things that you're doing really to focus on participation, and promoting positive mental health throughout the day?
Well, you mentioned band, and you mentioned doing work that really helps children do more than that 30-minute session. And so the programs that we envisioned were really embedded throughout the day, in the classroom, um, in the lunchroom, recess. The OTs, when we were envisioning these, they said, meal times is a part of our scope of practice. Play and social participation. Why aren't we automatically leaders and really helping foster health during lunch and recess? And then making leisure matter. There's so much literature on the importance of structured leisure. Reed Larson's work on youth development. And I find that leisure is one of those forgotten occupations for a lot of OTs, but we even cite part of the law that states that if students with disabilities need supports and services to help them participate in leisure, it should be provided. So I will start with that one. Making leisure matter is really based on occupational justice, that all children should have a right to participate in meaningful out-of-school leisure. And so we started out with individual leisure coaching for children and youth with disabilities or mental health challenges that had no leisure. And we developed OT leisure coaching steps to help them participate. And then we really branched off into more a tiered approach to leisure promotion. What could we do at tier 2 with those at risk? So some of the small group interventions that actually at the Cleveland Clinic Children's Rehab, they've developed a lot of leisure groups that work on fostering hobbies and interests. And we also do some tier 1, what could be done at the school-wide level to foster leisure. So doing an environmental scan of leisure in the community, sharing that with parents. So that's one of our initiatives. It's a lot of fun. And the cafeteria and recess programs are 6-week, 1-day-a-week programs that really focus on promoting participation and enjoyment for all students and building capacity of supervisors to be effective in their job. Most of the time, they're not given any information. So principals love these programs, and we really focus heavily on those soft skills that kids can develop during these unstructured times. So you can work with children one-on-one in a little room, but learning occurs best in the natural context, doing real things with real peers. So we do focus heavily on friendship promotion, how to be a good friend, having a mealtime conversation. It's a life skill. Respecting differences and including others, eating healthy, and then certainly during recess, active play. And so we have seen, due to the pandemic, I describe it as an occupational disruption that has decreased opportunities to participate. And then what we're seeing in kids is decreased occupational endurance. The endurance needed to concentrate throughout the day, to socialize throughout the day, to interact with peers. And so then what we see, I'm hearing a lot more reports of bullying and depression, anxiety. So really a lot of the Every Moment Counts programs are in huge demand right now. Mental health is across the globe, from invitations to speak in Pakistan to Ireland to the UK, and I'm doing a lot of it virtually, but it really has caused some disruptions. So that's a little bit about our programs. And then the other one is really building capacity, really doing a lot of work to build capacity of school personnel
Hmm.
to promote mental health.
Gotcha. And I think as you said, it's such a root to our profession, and it's just helping. Some programs I think spend a little bit more time or emphasis on it in terms of what their curriculum is and the opportunities they provide students. But it's how I think we're different than some of our other rehab colleagues, and it's a lot of what we have to be value added to a school, certainly, and then in the other work that we're doing. I know even in the adult rehab world, there's more emphasis now on leisure, certainly in terms of looking to be a little bit more universal in the types of evaluations that we're doing and the interventions that we're providing. So do you want to talk a little bit about the types of service delivery models that are important for occupational therapy practitioners as we're looking to provide these kinds of initiatives?
Right. I think, as I mentioned before, shifting from a pull-out clinic-based one-on-one model to an integrated model. And I think one of the myths is that services need to be, when people hear educationally relevant, they think it has to be in the classroom. But we really need to focus on both academic and non-academic settings. So sometimes when I present to therapists and I'm talking about our cafeteria and lunch programs, I almost see a deer in the headlights look. And at one state, someone raised their hand and said, I never thought about being in the cafeteria before. And so this is where I think we haven't taken seriously our full scope of practice. And that's one of the things that we're trying to really hit home with. The other thing is really shifting from a bottom up to a top down model. So bottom up, just looking at component function. And in Ohio, for example, there's been some issues recently. The reason for referral form for OT has fine motor listed with a check. You could check that or other. And so some OTs are saying we only could address, or some supervisors saying we could only address fine motor. And this is where we have to be myth busters and assert ourselves related to misinformation. That first of all, we better know the law, because the law idea states that we focus on participation, function, even prevention. but it doesn't state what areas we address as OTs. We define that based on our scope of practice. And so that's where we have to keep going back to scope of practice and correcting misinformation. So I think this is an issue we're trying to tackle in Ohio. And OTs who have OTs working in the state departments of ed, and I presented in several states where that's the case, and we used to have Kathy Chiney in Ohio who was representing related service providers, but we have to have a connection at the state level to be able to influence how they're saying that we're defined. And too many OTs are supervised by non-OTs. But in districts like the Cleveland district, even Columbus, where there is an OT director, then it's easier because that leader, that person can articulate our role and supervise whether it's 20 or 40 therapists, in that area.
Right. And so related to that in terms of, I think we fought long and hard to try to get Medicaid reimbursement in the schools. How do you, in terms of that one-on-one service delivery, how do you negotiate that? Is it, so I've been very fortunate in my career that my school that I did my where I was kind of a paid consultant at a school was really to help whenever the OT there was kind of overwhelmed by caseload, because most of the kids at the Ohio State School for the Blind where I was needed OT services. But the superintendent was wonderful and basically said, whatever a kid needs, a kid gets. I certainly didn't know who was on Medicaid or who wasn't on Medicaid in terms of billing and reimbursement. But I know I've talked to some OTs that feel a little bit of pressure in terms of kind of maintaining that one-on-one billable service and that sort of thing. How do you kind of address that?
Oh, it's very complicated. Some schools are not they don't even bill, the wealthier districts. So there's so many differences. OTs who are hired by the school themselves tend to become a bigger part of the culture of the school. And I know many OTs that if they feel something is needed, they do it within our scope of practice, and they're running small bunch groups or doing some of our universal programs, and making the case for it that they are serving kids on their caseload. So I think that threw a wrench in this whole individual needing a plan of care and all of that. I would just say I would keep going back to the law idea that even 15% of funds are allotted for children, students not on our caseload.
Right.
That's part of RTI. So I do consult with practice senderos, and when you have the leader at the top saying, I want you to work within a workload model and provide tier 1 and tier 2 services, I think that changes and nudges therapists and moves them out of this direct one-on-one model, which is not best practice. And so I think the more we have therapists who are doing that and leaders and demonstrating our value in that regard, then we have to apply some of these other strategies like coaching. Again, I think small groups are very powerful. And environment-focused intervention. That was, you mentioned Canadians, ANAB, and really environment-focused intervention is when we change the environment, we can impact the person's participation. And I think we've always done that as OTs, but now we have a term for it.
Yeah, and I think too, like when you look at other teachers that are more specialists in terms, that are not classroom teachers, but maybe they're a reading specialist or whatever it is, they're providing interventions in a lot of different methods. They're not just doing one-on-one interventions with kids and pulling them out. Like, so even within kind of, my wife is a teacher educator, so sometimes we have some of these discussions over dinner about some of the ways that we interact. So do you have an example of maybe a school district that's done kind of a really nice job of kind of moving beyond kind of that one-on-one clinic-based model?
Well, actually, when we were starting our work in 2011, Carol Conway, who is a therapist at Hudson City Schools, a wealthy district, she knew they were really stuck in this pull-out, one-on-one therapy model that she knew was not best practice, but that parents really viewed therapy as their kids go to school not just to be educated, but to receive therapy. And the bottom line is children receive therapy in schools to help them participate. So what we started with is this, and Carol always said we can't do every moment counts work if we're doing just this one-on-one pull-out model. So what we did is we started the conversation. We did an in-service with related service providers and the director of special ed to get everybody on the same page about why integrated services is best practice. It's the law, and theories of motor control and motor learning support that, etc. And so we got the therapists, related service providers on board, and then we decided, instead of announcing, they were very concerned that if we announced we're going to do this integrated model, parents would would push back. So we developed a community of practice in the school where we invited representatives from paraeducators, parents, speech therapists, teachers, special and regular ed, administrators. And we did a couple in-services, short ones, and then we had discussion groups, and we said we're going to look for the open doors and start integrating services, demonstrate the success stories. And so it was really a lot of awareness raising, and within about 9 to 12 months, they shifted. The therapist did a time study in the beginning looking at service provision. They shifted from 40% integrated to 80%. So it does take strategic thinking and getting everybody on board. It was very successful.
Well, it's interesting. I during COVID was helping to supervise some level one students remotely, so that at a residential kind of a pretty exclusive residential school, and so I had some level one students, and one of the things one of the questions that the students started with was, have you ever worked with an OT with these transition age students? And all of them had learned to ride a bike from the OT in this high-end, residential school, and it was a bike riding class that they all had. And I just thought, if you have, a place that is obviously not billing Medicaid, is, kind of really the OT there in the administration is really looking at what are the things that are important that these, young people are really going to need later on. And it was, well within our scope of practice, and all the kids raved about their great OT experience, because of, important, focusing on the important things that are going to, hopefully give them a skill for a lifetime. So when you think about our practice in schools, and you've used the word distinct value, what do you think it's really important as we're sharing that with administrators, families, other personnel in the school, so that we're kind of practicing in the way that we think is going to help the most number of kids and really have the best outcomes?
I think it's participation. And, not everybody understands the term occupation, but I like to think of the activities, interactions that foster health within our scope of practice, those 9 areas of occupation that are listed in our practice framework. So, I think certainly we came into schools with special ed legislation. 1975, the floodgates opened. And, it just, we are the third largest practice area. So legislation is critical. But secondly, what's happened since 2015, the ESSA, Every Student Succeed Act, which replaced No Child Left Behind, is focusing more on health, mental and physical health within MTSS, so these tiered systems of support. And we are listed as SISPs. That's a hard one to say. Specialized Instructional Support Personnel. So that legislation was enacted in 2015, giving states, kind of they're responsible for implementing this law, coming up with their guidelines, et cetera, their plan. And so one of the problems is related service providers are listed as SISPs, but we're really not at the table yet. So this law, No Child Left Behind, focused a lot on testing and academic success. This law is really focusing more on health. So that's the other thing. There's more and more emphasis on health, that when children are healthy, both physically and mentally, they do better in school and in life. The other thing that's happened is this whole child framework. It's actually whole school, whole community, whole child framework is being adopted throughout the country in most states. Ohio Department of Ed, for example, has adopted it, and we have this whole child framework advisory group. I've sat in during COVID on some of their virtual meetings, but we don't have related service providers represented in that advisory group or ESSA. ESSA in most states they have to have an advisory group. Related service providers are not represented. So one of the challenges now I see is we are so pigeonholed into special ed and needing to be educationally relevant that the rest of school population, school personnel don't, I think, always recognize us as healthcare providers in schools. So actually, one of the whole child framework meetings, there was, I think, an OT from Children's Hospital in Columbus. Well, why do we have to go to a hospital-based OT to advise us on school health when we have OTs and PTs in schools that can be utilized? So that's right now, I see a big tension across the country that we are not at the table related to these health initiatives, and more money is going into school health centers, and we're just not at the table. PTs could be addressing obesity prevention, physical fitness, and we can certainly be addressing mental health, social, emotional health, and so I see it as a problem. I see us needing to advocate and be a part of those state advisory committees.
So do you have advice for OTs out there that are interested in getting to the table? How do we get at the table? What would maybe be a first step be for them?
Well, I guess I could describe, maybe things we can do at a district, at a state, and then national level. So at a district level, I do know, and many districts have wellness committees. In Cleveland district, I know Karen Thompson-Repus is the OT director. She and some of her OTs and PTs do attend their monthly wellness committee meetings. And I actually presented on the Comfortable Cafeteria at one of them. So I think looking at districts and at the school level, what committees are there that we should be at the table for? I know OTs in other states that are on their school's mental health advisory group, or PBIS, or SEL. So I think we need to make sure we're at the table, even at a school level. At the state, this whole child advisory committee, I have contacted them. to try and get on that, and I missed the deadline. They don't advertise those things very well, but I think we need to look into those kind of advisory committees, and even where money is going for school health, and see how we can, access that. So ESSA advisory committees, for example, I've never seen any state where an OT is involved. And then at the national level, actually, I stay connected to Abe Saffer, who is our lobbyist that oversees school-related legislation at our national level. And he, probably 3 years ago, started kind of just pestering me and saying, why don't OTs know about ESSA? Why aren't OTs doing anything about it? So this would happen every couple months, and I decided that we should do something about it with Amy Cooper Smith, who's an OT in New York. She worked for the New York Department, their New York schools. Pam Stevenson, who's been involved in AOTA, she's in Virginia. We decided to start this grassroots OT ESSA advocacy network. And we decided not to do it under AOTA because we knew we could do things more quickly and also involve non-members. And so it's very grassroots. We have about 3 virtual meetings a year. We have already over 250 OTs. So it's just word of mouth. And our goal is to educate OT practitioners, and we have some students, about ESSA, have a platform discussing how can we be at the table and address health at Tier 1 and Tier 2, and then share success stories. And it's been really exciting to see the OTs who are already doing Tier 1, Tier 2 services that address health, social, emotional, physical health. And so we developed 2 information sheets they're going to be shared with this podcast. The short one is for school administrators to educate them about our roles under IDEA and ESSA, and then our scope of practice. And the longer one is a little more dense. It's for OT practitioners to educate them. So I think that's a start, but...
Yeah, do you know, I wonder, so I'm involved in a lot of things that involve the Workforce Innovation Opportunities Act, which is specifically for employment for transition age students with intellectual and developmental disabilities and other disabilities. But so every 3 years, the state has to do a report to the federal government to kind of give them an update. I don't know if ESSA, I don't know if they, maybe you've got a student around somewhere, or yeah, I'll do some looking too for you to see it, because every state has to have a plan in terms of how they're addressing some of these federal initiatives, and kind of have a regular report card. And then I know for the Workforce Innovation Opportunities Act, every 3 years they have to update it and give them. So I don't know if that's a way that we can get on the inside, and because as you said, there are people that are making decisions that are trying to make the best decisions they have. But if you don't have an occupational therapist that's there and talking about how we can support those folks, then they don't know what we can do sometimes.
Right, we're underutilized. So I presented recently in Arkansas, their Department of Ed for related service providers, and the OT who represents, who's with the Department of Ed, said we're just so underutilized. It's like we're so pigeonholed into just working with kids with disabilities that this whole knowledge that we have about health is not being utilized. And we have so much to offer that can help all students be healthy, physically, socially, emotionally. So, and I like to think for OTs, what makes us very different in the mental health realm, I like to say that we do doing therapy. We don't do talk therapy. So we help children participate in the things that we know will help them be mentally healthy. So I think it's really critical that were a bit of a squeaky wheel, like Abe was with me,
Yeah.
and that people eventually say, and there are a lot of OT practitioners across the country very interested in ESSA. Capstone students I hear from, they want to be on the network. They're very interested in ESSA. So I think that's a really good sign that just talking it up, having a platform to convene that's not requiring money, and it's not overly involved in terms of time. I think too many groups have monthly meetings. It's just too much. But maybe 3 meetings a year can do some nice things. We record our meetings, we share information in our Google Drive folder. So we try to keep it simple.
When we were sharing resources before this, I loved your occupation wheel. Is that your own creation that you created to help explain our scope of practice? And our listeners will have access to this after the podcast as well.
And I do love that. So I did see it was a social work scale that used a similar circle with the areas that they were looking at. But obviously, I developed this one. My daughter's a graphic designer.
Oh, that
She's my
helps.
designer. Yeah. And so we basically, I was looking at AOTA's website and other websites. I could not find anything that was, clear in depicting our 9 areas of occupation that we address. And I think we need something like this because I look at a lot of evaluation forms that tend to still be bottom up. Fine motor, handwriting, visual perception, sensory processing. And I want to say, where's the occupation? So this graphic then takes those 9 areas, and we came up with, there was a group from this ESSA network that gave input to what are the things that we would look at in children and youth during the school day. And so we came up with these, and we've actually applied this. I am in the process of developing an occupational therapy wellness screening that would kind of look at wellness in these areas of occupation. And in consulting with Sendero therapists in presenting this and then having them pilot the screening, we kind of looked at how it shifted their practice. And over a period of 3 or 4 months, they had to come up with action plans. More were addressing health management, mental health literacy, health. More were addressing sleep and rest. More were addressing leisure and play and social participation, areas that they hadn't typically addressed. So I do think it could help therapists, but one of the sheets then could be used to share with other school personnel. And one of the OTs in a school in this region shared it with the school psychologist who oversaw referrals for OT. And she just had that little fine motor thing. And she said, you know, I didn't know you addressed all of these areas. We need to change this form to depict more of the things that OTs would address. So that's education. We can't just hand people the form, though. We have to hand it to them and then talk about it and give examples of how we would address these areas of occupation. I do know OTs who are addressing like sleep, rest in school. And that could be embedded in a handwriting lesson. There's a lot of great resources on sleep rest. And
But you think about when you look at, and it is a very cool wheel and people have access to it. So you think about talking with a parent about the goals that you're working on with their kid. And what do they want you working on? So like really, do they care about handwriting, or do they care about, kind of some of the bigger issues that all of our kids struggle with, to really help them with the big picture. It reminded me a little bit of a service menu in terms of, we have a transition service menu that I had come across for transition that really just kind of defined what our scope of practice is for that age group. And so but I just like that it's so much, it's a bigger picture in terms of what it is that we actually do or what we can do when we have, kind of motivated therapists that are really kind of able to see the big picture and again, that child's long-term outlook.
Right. I mean, and I think we just have to have it as a part of our lens. One of the OTAs in the region, I asked them to tune into recess and lunch, and for a couple kids on her caseload with autism or autistic children, they couldn't go outside for lunch because of safety issues. And she just said, this is not acceptable. So she made a point of taking two out with her at a time to really work on safety issues, play skills. That's advocacy. That's demonstrating our value. If therapists were saying this past year that kids were eating in their classroom watching videos. So with a health lens, for us as OTs, we should look at that and say that's not a healthy practice. And that how can we change that scenario? We can put a conversation starter on the whiteboard and encourage conversations during lunch or whatever. So I think it can be helpful with nudges for therapists to really think about what they're doing.
Yeah, and I think you're right that um, it's not the. I mean, sometimes we have to question what we're being asked to do because it's not always really what's going to be the best interest of the kids that we're trying to support. So, do you want to just talk a little bit about so how would people get information? We're going to have these documents on occupationaltherapy.com, but if they're interested in the OT-ESSA advocacy network you're part of, how do they get access to that?
Okay. Well, two things. For Every Moment Counts, when you go to the website, and this is the second iteration, it really is dense, information dense, and it really needs to be approached like a book. Everything's free and downloadable since it was grant funded. But sign up to stay connected. We had live webinars this past summer with a lot of our OT change leaders. We will be selling them on demand in the fall. But there is a free online course that I developed with Dr. Sarah Nielsen from University of North Dakota. It was SAMHSA funded. And I'm sharing an information sheet on that and then the link. So for people who really don't have funds, they could use these resources. There's 5 one-hour webinars with facilitation guides to guide a team to learn about this and then think about how they would implement it. So that's Every Moment Counts. For the ESSA, right now people can email me, and I believe my email is on those information sheets. The OT ESSA Advocacy Network. We do have a Facebook page, which is fun. And sometimes it's more active than
I'm
not.
on that Facebook page.
Yes, and so it's a nice way to share any information related to ESSA, school health, Tier 1 and Tier 2 services. So those are 2 or 3 actually strategies.
Wonderful. Well, Sue, thank you so much for your time. I know that our listeners learned a lot. I certainly learned a lot. And thank you also for what you do for the profession. And I think you've certainly transformed the way that I think about school-based OT. And I know you've done that for literally thousands of others to the benefit of thousands and thousands of kids that we serve. So thanks for all that you do. And look forward to talking to you again soon.
Oh, thank you, Dennis. It was a pleasure. And I always say, stay the course. There's a lot to do out there.
There sure is. Thanks so much.
Okay, thank you.